Hi, I'm Tony Yeung. I'm pleased to present this talk from the Master's Podium on the role of endoscopic spine surgery in the treatment of painful degenerative conditions of the lumbar spine. This describes my 27 years experience focusing solely on endoscopic spine surgery. This is the least invasive of all the surgical techniques, offering a path between surgical intervention and pain management. This talk may be disruptive to all the surgical specialties promoting advances in spine care from their own narrow perspective, and that is making it more tenuous in affordability because of the expense required to facilitate these advances. When all the biggest innovations in spine care is considered a right without considering affordability, this makes it even more tenuous because we do not have enough money to provide the best care without any restrictions. Now, going back to the premise of low back pain. Common low back pain, even in patients who are asymptomatic, has a high risk of eventually developing low back pain, and it's estimated to be at least 80% in your lifetime. Studies by the University of Hong Kong on common low back pain shows that back pain begins in the disc. Disc degeneration in asymptomatic patients with this study, I identified the high risk of patients eventually developing back pain. They even developed a new biomarker in ultra short time MRI sequences that can identify a degenerative disc better than traditional MRI. There are other studies by a company called Nosomed that will look at the spectrum of acidity in the disc and correlate that with disc pain as described by evocative discography. Endoscopic surgery is the least invasive surgical procedure to treat the pathoanatomy of chronic low back pain and sciatica. This finding on discogenic pain supports endoscopic spine disc decompression as the least and most effective surgical procedure to treat chronic back pain beyond just masking the pain. The clinical rationale is this. There are lots of methods to treat back pain by various providers. The clinical rationale supports that endoscopic surgery is very cost-effective, especially when combined with endoscopic rhizolysis to treat common back pain without expensive implants. This delays fusion, even if indicated as a later or last salvage procedure that avoids burning bridges for fusion later in the degenerative cascade. So we are all emphasizing evidence-based medicine. But what is evidence-based medicine? It is an approach to patient care that emphasizes a knowledge of the current and best clinical evidence available for making treatment choices for our patients. Even if evidence-based medicine is considered the standard of care for clinical treatment, we may need to evaluate why even level 1 and level 2 evidence-based demonstrations can create different conclusions by different clinicians. What is evidence-based medicine? Evidence-based medicine is meaningfully applied to modern clinical research, which is the mainstay of Western medicine. Why do we do clinical research and how do we validate it? We accept the fact that the research design allows us to rate clinical data into different levels of evidence 1 through 5. These are the grades that as providers, as academicians, we tend to value level 1 and level 2 randomized studies as adequate. However, all level 5, 1 and 2 evidence starts with level 5 expert opinion. This is where we need to have more level 4 and 5 publications where the levels 1 and 2 begin. The practice of evidence-based medicine is really the integration of clinical expertise, patient needs and values, and best research evidence. Evidence-based medicine is what almost all physicians feel that they are already practicing. Medical schools teach and use the scientific method. Many read medical journals appropriate to their practice. On clinical expertise and education, what you think you know may no longer be valid or become disproven over time with future research. What you want to know is impossible to completely assimilate at one time. What you need to know may be very hard to find. So patient values are also very important. Each patient brings a personal set of needs, knowledge base, and personal beliefs to the patient-physician relationship. Patients rely heavily on the recommendations of their physician for personal choices. Physicians offer guidance to their patient for a joint decision of their choice. So really, the best research evidence is to reduce bias, which is very difficult to overcome. It minimizes outside influences. It promotes ethical clinical decision-making. The practical information are that for the practitioner, we want to improve patient care. For the clinical scientists, we want to elevate studies to higher levels than level 4 or 5 case studies or expert opinion. For the published article, it provides more recognition for being accepted by your colleagues after peer review. This is the goal of all young surgeons. So what I hope to bring to physicians involved in spine care is that I want to impart what I learned and what I want to share of my 27 years of specialization in endoscopic spine surgery. In endoscopic spine surgery, cooperation is needed because there are more than one specialty that can handle the various aspects of spine care. The training for each specialty is different, the background is different, concepts are different, and experience are different. Also, technical abilities are different, and surgical training is always desired. The decision-making and surgical skills are both necessary to go together. In order to achieve the desired results, I emphasize surgical training for the background it brings to the practitioner in providing care and make it safe and effective. Safety is utmost. The endoscopic surgery advantages are that the endoscope makes it possible to correlate the pathoanatomy of pain with visualized pathoanatomy. It is possible to see the results of pathophysiology by looking at the pathoanatomy that causes pain, especially if the patient is operating under local anesthesia when he can communicate with the surgeon and provide feedback during the surgery. So therefore, the physiology of pain can be correlated with pathoanatomy, which is a topic that most traditional surgeons cannot appreciate if they operate on people under general anesthesia. So I want to emphasize that the E in endoscopic evidence-based medicine is not just evidence-based, but is endoscopically visually based, it is expedient and efficient based, it is economically based, and is expertise based. So there are at least 5 E's in endoscopic based medicine. Let's go back to the degenerative conditions of an aging disc. This can surgically treat the pain source as guided by imaging. All discs undergo degradation in a well-described cascade matched by imaging and pathoanatomy. Wolfgang Rauschning has been instrumental in identifying the cryoanatomy of degenerating discs. Fuhrman has graded these degenerative changes with this publication in 2001. All of this can be facilitated by using diagnostic and therapeutic injections to identify the source of pain, and then we can use imaging in order to identify the pathoanatomy. Pain generators in degenerative disc disease affect the DRG, which is responsible for the reason why some people can tolerate pain and others cannot. The dorsal root ganglion is the brain of the nerve and is extremely sensitive. It's almost never seen by traditional surgeons. On the left, the cryoanatomy slide by Wolfgang Rauschning shows evidence of granulation tissue, which is the source of pain and can be visualized. And if we were to look on the right, you can see the proximity of the annulus to the facet joints, and to the dorsal root ganglion. All of these pathoanatomical sources can cause pain. And here you can see the disc, the facet, synovium, the osteophyte, and the dorsal root ganglion. So I now want to offer some disclaimers. What I tell you, you can consider level 4 and 5 evidence-based surgery based on my clinical experience and success that I have documented by visualized pathoanatomy from endoscopic images in patients using anesthesia only. I am over 10,000 cases at this point since 1991. This is the lowest level of evidence-based medicine, but all levels of evidence-based medicine start with level 5 expert opinion. So I am very conflicted. And by being transparent, my 27 years and over 10,000 endoscopic surgeries are based on personal observations, just like the cartoon on the right, when the Neanderthals killed an elephant with a single arrow, and he said, we should write that down. So I also developed the endoscopic spine system called the Yeung Endoscopic Spine System in 1997. So since then, I have published over 100 level 3, 4, and 5 evidence-based publications. But truly, what I'm offering you today is merely a level 5 expert opinion. And on the future of endoscopic spine surgery, I think it's going to be utilized by non-surgeons as well as surgeons. The acceptance will depend on the politics, physician acceptance, and the business of spine in various parts of the world. Medical and political turf battles are always going to be present in every country. So the purpose and the future of endoscopic surgery, in my opinion, is going to be surgery not just for a neurologic deficit or an abnormal imaging study or a last resort for surgical intervention, but transforaminal decompression will be for surgical pain management under local anesthesia. And I emphasize local anesthesia because it will require the surgeon to have enough expertise to feel comfortable operating on their patient awake. Because if the patient is hurting and they shouldn't be hurting, the surgeon needs to be aware and be able to adjust his technique. How endoscopic surgery should be utilized is with a proper endoscope. The original endoscope I developed in 1997 called the YES multi-channel flow integrated spine scope is this. We use the endoscope as a surgical tool. We use it for discectomy and nucleectomy. We use it for decompression, and we use it for intradiscal therapy. That inside the disc, we will still decompress and use thermal ablation and disc irrigation to irrigate the acidic components that cause inflammation. So the Wolf's YES endoscope design is ergonomically designed and configured for intradiscal visualization and therapy as an emphasis for those adopting endoscopic spine surgery. 90% of back pain originates in the disc. So further explanation of my design for the YES scope is this. First, it is oval shaped, not round shaped, to allow the scope to be inserted into narrow disc, which is usually at 50% is 5 millimeters. So 4.5 will allow me to get inside the disc. The endoscope have integrated channels that is flow, pressure, and controlled, and this will provide maximum visualization. I can control the pressure and I control the flow in order to keep the visualization as clear as possible. It has irrigation channels that a laser fiber can also be inserted down one channel for laser ablation. But now that we have different laser probes, we can use the operating channel as the laser channel. But If this is not available, you can actually put a laser fiber down one of the irrigation channels to use that to help facilitate decompression ablation. So the YES system basically is combined with a system called Vertebras, a design that I combined with German surgeons and engineers to use a 2 millimeter to 4.2 millimeter working channel for surgical instrumentations. Some of the newer endoscopes, because they have newer technology, may be able to offer such a large working channel, even with the oval-based shaped endoscope that is 4.5 millimeters to allow for the flow integrated irrigation. Multiple endoscope systems are being marketed. Some of you buy different systems because you get better service from the marketer. The YES system, unfortunately, has been marketed the least aggressively to promote the reason for my original design. Laser is a valuable surgical tool that facilitates endoscopic surgery. Traditional surgeons have been against this because they don't use it and they tend to want to disparage it. Others use it as a marketing tool rather than a surgical tool. So this is a valuable tool that in the right hands is going to allow the advancement of endoscopic surgery to make it much easier to perform decompression and ablation. The other system that is readily available at this time is the Eloquence bipolar radiofrequency rhizotomy probe for endoscopic ablation. It has been validated for safety by studies done by Stefan Hellinger in conjunction with Wolf. The double-prong probe with the standard Elman, used to be Elman, but now Eloquence bipolar trigger fix probe, has never caused any thermal energy based on my last 9 to 10,000 cases. And safety is emphasized. In addition, in evolving the technique, the YES rhizotomy set by Wolf for axial back pain is shown here. And the bevel design provides surgical identification and also a window to do foraminoplasty to follow the nerve into the facet joint that is not possible with traditional pain management procedures. Here is an example of how it is used visualized. You put a needle to the base of the transverse process, and we can then inject dye to see if there's communication with the foramen, which will allow us to look at nerves as seen on the lower right-hand corner that you can visually decompress, ablate, and irrigate. So the endoscope is needed when you're looking at anatomy. And one of my fellows, Dr. Yeung, who studied a year with me, found that the dorsal ramus can be identified in the foramen and not just crossing the spinous process, the intertransverse process. Sometimes, if you are using blind techniques, the medial branch is protected by an osseous tunnel, and the energy used to ablate the nerve is not adequate. So therefore, most pain management doctors accept the fact that the effect of rhizotomy is limited because they do it not under direct vision, but by positioning with a fluoroscope. So the endoscope is designed to identify painful pathoanatomy, not only transforaminally, but intradiscally, in vivo, for an endoscopic treatment of the lumbar nerve. I have published on this with Dr. Satish Gore in multiple publications from the Surgical Technology International Journal. The last one is in 2012, the 21st version. With this, I believe we have validated with the patient under local anesthesia for the ablation and treatment of the pain generators in the spine. Since 2015, I've realized that it is much easier to express my views in open access journals. So one of the first publications I gave was moving away from fusion by treating the pain generator the secrets of an endoscopic master. Other concept papers published in the Journal of Neurologic Disorders include Transforaminal Endoscopic Surgery, its role in the treatment of painful conditions of an aging spine, and Intradiscal Therapy and Transforaminal Endoscopic Decompression Opportunities and Challenges for the Future. My procedure publications in 2016 are to talk about a hybrid procedure in lieu of fusion for the treatment of instability in back pain and degenerative changes in back pain. So we have the anterior column and posterior column. So this way we can treat both anterior and posterior column at the same time. And for the future, intradiscal therapy and nucleus augmentation as a surgical technique may involve biologics and some type of implants that's going to reinforce the lost support of the disc. There are multiple publications in 2017. Robotics for endoscopic spine surgery, selective endoscopic decompression in athletes, treating the pain generator, my 25-year experience in endoscopic surgery, the state of the art, failed back surgery, and percutaneous endoscopic lumbar discectomy in China, which is the generic form of selective endoscopic discectomy. These articles are growing from Western, Korean, Chinese, and Indian spine surgeons who are adding to the literature, and they are listed on the right-hand column. Since the last 2 years, as I published, I've been asked to be editor-in-chief of 3 journals that are open access. And based on my 25 years experience that I've published, I'm getting requests to provide you with talks like this Master Talk. Finally, foraminal endoscopic minimally invasive versus pain management is illustrated that formal training and mentorship is desired, but it's also rare. It is universally not taught in spine or pain programs, so those who advance it have to do it on their own in a private setting. For the future, I am helping a company develop an endoscopic spine trajectory using a surgical robot that will take my artificial intelligence and direct the patient to the perfect trajectory in order to reach the pathoanatomy. This is helped by one of my fellows, Girish Datar, who was able to identify all the different areas where the pain source begins, as you can see from the various colored dots. In order to reach that area, it can be accomplished by using a certain trajectory and rotating it with different trajectories for cannulas to visualize the pathoanatomy, just like visual flight rules for a pilot. Each trajectory is programmed to provide ideal access to visualize pathoanatomy, guided by the MRI and the CT scan using bone as an anchor. Therefore, treatment options bridging the gap is first with conservative treatment, then with interventional pain management and spinal cord stimulation and DRG neuromodulation. On the surgical side, we have prosthetic surgery and fusion, but the gap is going to be bridged by endoscopic spine surgery, which I hope I was able to convince that this can be done effectively and safely. So there are really different techniques. This is a slide courtesy of Luke Kim, and he talks about the 2 major techniques, the inside-out technique by me and the outside-in technique by Hooglin. Hooglin, after debating me, has actually adapted his technique to Maxmore, which de-emphasizes reaming outside the cannula, but more reaming inside the cannula for safety purposes. In reality, there's an overlap, and the conversions of fusion techniques and endoscopic techniques tailored case by case is going to affect what we call the targeted technique, whether you use inside out or outside in philosophy. I support rational open techniques that will be able to support endoscopic techniques, but this will require training. Here I have a group of fellows who are visiting me in Phoenix in workshops to learn the yes technique and the philosophy. To summarize also, some of my students who are now very experienced, Dr. Zifeng Zhang from Beijing, has trained with me, with Dr. Zhou Ye, has trained with Dr. Huglin with the thesis technique, has trained in Korea, and has gone to various cadaver labs. He summarizes that the yes technique is an easy technique, which it really isn't easy, as you can see, with all the trajectories of different cannulas. But what he considers easy is that once you get the philosophy and know how to reach the pathoanatomy, it becomes easy because you can visualize the pathoanatomy. The other expert, Zhou Ye, is now calling his targeted technique the Zisys technique. And basically, he is using a combination of the inside out and outside technique in order to reach the framing, which you see with the red dot. That is where most of the pathoanatomy of failed back surgery resides, and it's not seen by traditional surgeons. So I summarize by saying the yes philosophy and technique identifies painful pathoanatomy and painful conditions in a patient under local anesthesia. With direct visualization, it will provide you valuable information on surgical anatomic variations. Following that, I was very pleased that Zifeng Zhang started the Yeung Endoscopic Spine Society as the first president. And this was presented at a neurosurgery meeting, functional neurosurgery, where neurosurgeons who are focused on doing epilepsy and vein therapy is now hoping to branch out into pain management. So these are some of my fellows. They're from all over the world. Most of them are Asian. And you see Dr. Girish Datar there pointing out that the inside-out philosophy is part of endoscopic surgery that needs to be embraced. So thank you very much for listening to this talk. I hope that this will give you the stimulus to look at the cause of pain in your patients and use ethical techniques to decide which part of the technique is good for you to do it safely and effectively for your patients.